I wanted to welcome everyone to one of the first, I don't know if this is, I think this may not be the first, but it's been the first in a while, so I'm going to call it the inaugural Sam Shapiro Lecture. We're very privileged to have here as our speaker Dr. Robert H. Brooks, and I will say a bit more in a minute.
That's enough. The president says all you have to do is say, I'm the president, right?
That's right. Just a word about Sam Shapiro. Don Steinox would give these remarks, but he is in Australia, so he's not available at the moment. But Sam Shapiro was the director of this center, and he had the distinction of having a BS in mathematics from Brooklyn College, but that was the only advanced degree that he ever got. He did not have an MPH, he did not have a PhD, he did not have an MD. He was actually a senior director at the National Opinion Research Center. He became director of the Health Insurance Plan of New York and then came here in 1973 to be the director of this center. I think that there had been a couple of directors, in fact, folks that Bob knew prior to Sam, but Sam was director for many years. He, in fact, came to the office every single day until 1999. He would always wear a beautifully tailored suit from Saks and a tie and expensive shoes, and really worked. He passed away in 2000 at the end of '86, but he's had a lot of influence on this department, and it shows you can be elected to the Institute of Medicine and win every prestigious healthcare research award without any advanced degrees, or at least maybe you could once upon a time. Anyway, I really have the privilege of speaking for a couple of minutes about Bob Brooks. So Dr. Brooks, before he was Dr. Brooks, grew up in Arizona, where he went to the university and was quite a accomplished tennis player. He came to Baltimore in 1964, and in the next 8 years went to medical school. Was an Osler resident in internal medicine, was a Robert Wood Johnson clinical scholar, and completed his SCD. So for those of you who are poking along, you can do all of those things in 8 years. He, while he was here, he began to invent the science of measuring the quality of care, and I think in many ways he can be rightly referred to as the father of quality of care research in the US. He did some studies of appropriateness, and his first two papers that he published one was The Effectiveness of Patient Care in an Emergency Room, published in the New England Journal in 1970, 2 years before he got his degree. And the second was also in the New England Journal. In fact, 4 out of his first 6 papers were published in that journal. So he got off to a pretty good start. But one of those papers, number 5, was quality of care for the disadvantaged. And I think that's actually a thread that he has published in the Journal of Community Health, and that's a thread that he has really followed all along the way as well. He went to Rand, where he participated in the health insurance experiment. In fact, he studied quality of life or health status. He went on to be the vice president and director of health for Rand. And I think it's pretty fair to say that he is one of the very few most influential people in healthcare research in the country. He had traditional impact. He published hundreds of papers, over 300 papers, in which can be found in PubMed. But as a measure of influence on healthcare, 82 of those papers were in JAMA. And many of them were commentaries, and some of the things that in some ways, the way that I first became exposed to his work was through those commentaries, because he had the habit of writing commentaries. Some of those commentaries recently written that you might have seen, Can Picori Become Relevant to Controlling Cost and Improving Value? Health Services Research and Clinical Practice. Disruption and Innovation in Healthcare. These are the sorts, can public release of performance data, release of performance data, what do we expect to benefit? He had the habit of, as he was writing these, to hand these to his scholars. I was sort of an honorary clinical scholar, and I'm very proud to claim him as one of my first research mentors. And he would hand students things that he'd written and say, what do you think about this? And I rarely had that much to say. I'd usually say, this is awesome. But I was really honored to be even handed something to look at and to think that he might. I really appreciated the fact that he thought that maybe I might have something to say. On a personal note, Dr. Brooks has also always been known for being a charming host, occasionally a little controversial. Those of you who had a chance to talk to him one-on-one have had a real opportunity to see how well he thinks and how much out of the box he thinks. I think that he always challenges us to be original and to be relevant. And he told us a story today about the most desperate hour of his time at Hopkins, when it came time to print his dissertation. I actually have a copy of that dissertation here. And so I wanted to know that this is in my personal library, one of my most treasured possessions. My real treasured memories are time that I've gotten to spend with him. And I'm very honored to present our speaker, Bob Brooks, Thinking. The title is Refining Healthcare Systems and Improving Health.
Thanks, Howard.
So it's actually a privilege to be back here. You guys really don't understand just how smart and bright and hopeful you all are, and I'm going to try to do nothing to change that situation. I absolutely believe that the future of the country largely depends on what the people in this room do. I didn't say the future of your PhD work depends on it. I said the future of the country, and I absolutely believe that. Otherwise, I would have not come across the country to give this talk. Now, I am going to begin this talk by saying that I'm not going to show you, I don't think, a single number. So for those of you that want numbers, you have to invite me back and we can go through numbers. But I'm going to talk to you about ideas, thinking, and what we've learned in healthcare research in the last 50 years and how it's relevant to us today. So I'm going to start by a book. So I gave you a list of books that are in front of you. I would hope that before another 2 years pass, you read them all. I would hope that to get into the School of Public Health, you'd have to read them before you come. I would hope that to get into the medical school, you'd have to read them. Now, you may want to play around with them and remove a few of them and come up with others, but these are 12 very interesting books. There's one book that I would start with called Sapiens, A Brief History of Humankind. Now, what's important about this book is that at the end of this book, the author concludes that whether or not you believe in God, we are now becoming godlike. And all you have to do is look around Hopkins and look at the number of biological basic science laboratories that exist to indicate just how godlike we've become. The evolutionary process that was described by Darwin is no longer relevant. We are speeding up evolution by exponential terms. And it took maybe tens of thousands, hundreds of thousands of years for the giraffe to get a really long neck so it could eat the leaves from the top of the tree. We're doing this overnight with humans, and we're not adjusting for it. So whether or not you believe in God, we are becoming godlike. We don't know what we want to do. We have no idea of what we want to use God, ourselves, to do. We're undecided. What's the purpose? And that makes us very dangerous. And all you have to do is look at the current political debates in the United States today to indicate just how dangerous we can become if we really don't know what our purpose is. So I thought I would begin this lecture with a purpose from, if I figure out how to use this thing. Okay. This is not what is the function of a health professional, but what is the function of a rabbi, written many years ago. To redress the grievances of those who are abandoned or alone, to protect the dignity of the poor, to serve the oppressed from the hands of the oppressor, to save the oppressed from the hands of the oppressor. What if we made this the purpose of a health professional and added at the end of the statement to eliminate the teaching of hate to our children? Now think about this. What if every new person that comes to Hopkins, new person, whether that is the person that cleans the floors or the person that's going to become the head of the neurosurgery department, whether they come as a faculty person, a student, or in any other role, had to spend the first month of their new time at Hopkins interacting with everybody and figuring out whether this is the mission of what they are committed to. This is why they are coming to Hopkins. How would that relate to the culture of health? Think about it. Now, let me add a point to this. I wrote a piece which I can't get published, and I'm going to spend a second talking about it. So the piece begins with a story. It says, you're an obstetrician, and you see a young woman who's 23, who has a family, a husband, and money, and you determine she's pregnant, and everything about her from a biological point of view is normal. And you write in your chart, your medical record that's electronic, that this is a healthy woman with a healthy appearing first trimester pregnancy. And 17 months later, this woman blows up half of San Bernardino. What if you're a pediatrician and you're in a practice and a 5-year-old child comes into your practice and everything is normal, loving parents, good school grades, you've done a complete assessment, no guns, and on the way out, the child turns to you and says, I hate black people. I'm going to kill every one of them when I grow up, and my mother gave me a toy gun. Is that part of what we mean by the culture of health? And how are we going to deal with the teaching of hate to our children? For those of you that really want to expand the role of medicine, to include this, go for it. You will change society. Now, when I was training as a physician at Hopkins, I did two things, basically. I tried to prevent death by doing many stupid things, such as putting ice water into people that were bleeding from an ulcer and torturing them to death if they didn't die from the ulcer itself, to giving lidocaine to people in the CCU, which proved to just kill people at the end, or to deal with acute things that may cause disability, like broken bones. I did very little else. And over the last 50 years, medicine has expanded its role to include injury prevention, immunizations, even worrying about wealth distribution, but not to dealing with hate. And I would argue that the health professionals of all types should come together to try to figure out Does public health have anything to do with the teaching of hate to children? And how do we eliminate that? And is the future of the world dependent upon that? And should medicine and public health be left out of it or be part of it? Now let's take a full stop. Tell me how I would introduce myself. Grew up in Baltimore. Age of 5, went to Arizona because my parents were looking for a job. My father during the war that's World War II, was 4F because of bad eyes. So he went to provide care on a volunteer basis to the American Red Cross, where you wore a uniform. He was assigned to the South in the 40s, observed unbelievable discrimination against blacks in the South, wrote an 8-page letter to the head of the American Red Cross. The next day he was shipped out to Morocco. And the letter was never answered. So that's my background. Came to Arizona. Grew up in a city where there was an enormous amount of equality. One high school, everybody went to it. There was very little racial and ethnic division. And then came to Baltimore, where every 3 blocks there was a different religion or ethnic group, and was somewhat stunned, absolutely stunned. And came here when the Martin Luther King riots occurred. And from this hall, I used to live in what were the compound over here. From this hall, on the 8th floor, I took a picture, which was out of the window of this hall, which showed the tennis courts that were right next to it, with white men in white uniforms. They were all men in medical school those days. Everyone wore white to play tennis, playing tennis. Next to it was the pool, and there were all women in bikinis swimming in the pool. Next to that was a chain-link fence and separated it from the street. On the chain-link fence was a bunch of doctors in long white coats, all residents, with stethoscopes, holding their hands across the chain-link fence to get liqueurs from African-American people who had just burnt down the liquor store that was across the street, and the liquor store was up in flames, and on top of the row houses were 300 Marines in full dress uniform. That's the Baltimore I came to. And I was a little bit stunned 50 years later to read something not quite so bad, but similar, that occurred before I came to this lecture. If you had asked me 50 years ago whether that would have occurred 50 years later, I would have said, no way. This is a city with the best school of public health in the world, the best health system from Hopkins Health System in the world. Surely there's enough money and enough ability here to prevent that kind of experience from ever occurring again. So my hope to you all is that you recommit yourself, regardless of what I say today, that if one of you shows up 50 years from now to give the 51st, Sam Shapiro lecture, that you come to a city that is very, very different from the one that currently exists today. So that's where I come from, and that's what I'm here to tell you. Now, in terms of what we've learned from healthcare, I'm going to go through some of the major things that we've learned, because I think what the field is at this moment is to take what we've learned in the past and begin to apply them to everybody so that we really produce a broad culture of health. So the first thing that we want to know is, what do I want in terms of health care? I want excellent care. Now, it stuns me that today, after this long endeavor at measuring quality of care, that my colleagues who have PhDs but no MDs call me up and say, which doctor should I go to get X, Y, or Z done? Wouldn't it be really interesting if I called up the mechanic of American Airlines and asked them, which plane should I fly to Baltimore from Los Angeles, because I want the one that is safe and won't crash? you would think that's an absurd situation. Is it absurd that there is nobody, whether you're poor or rich, that trusts us to provide excellent care? Nobody. They all believe they want to get a hand up because they can get a better doctor. It's not a better room, not more square feet, not better food. They want that too, but excellent care. Now, the second question is appropriate care. I want something to be done well, but I personally want to receive care only when the benefit is much, much greater than the risk. That's what I'd like to get. I don't want care where it's about equivalent. I'm risk averse. If I believe that the likelihood of a bad outcome and a good outcome is relatively equal, I'd soon not getting medical care. If I'm an economist talking to the policy people in Washington, I would prefer not to pay for that kind of equivocal care. But what I want really is appropriate care. And I want somebody to reliably assess it. And we are still publishing papers today that shows how unreliable the assessment of a doctor is about what is appropriate care for a given condition. That needs to change. And third, I want humane care. I want at least to be taught in a way that reflects some basic moral compass or human values. Now, I would guess we all could agree on that. And when I began 50 years ago, you couldn't measure any of this. We now have come to a point in time in this field where we have a lot of ability to measure all of this. We have not been successful in implementing it in the poor, the rich, or the middle class. Now, what do I want in terms of health? Now, I don't know how many of you believe, you're all young in this room except for a few people that are old, but most of you are young. Are you going to live to see the human race immortal? What do you mean by immortality? Will there be another species that replaces the human race? If you don't ask Albert to provide a lecture on that topic by somebody who knows something about it, you're not really fulfilling an educational mission. And if we're immortal, most animals that are immortal, like little worms that divide themselves in half and live forever, have only one sex. So which of us will be immortal? I vote for women. And why I vote for women is not that you're kinder and gentler. I'm not sure I believe that, having 3 daughters. But what I do believe is you have more chromosomal material. And therefore, we ought to save the chromosome and the extra chromosomal material and make women the ones that become immortal. And I do believe that within a century, if we're around as a human race, that women will be immortal. We will change the whole concept of what we mean by the human species. So that's one question in terms of health. 2 is to eliminate social determinants on health. Why do where we live, how far we commute, wealth, all those things you know about, affect health? Now, the really interesting question when you go to national meetings is there are 2 camps that talk about it. One are the biologists that are going to do it by something called basic science, and one, all of us, that are going to do it by really working on social determinants. Who's going to win this war? Are we both going to do it together? How are we going to put this together to make this happen? So will we eliminate the effect of toxic stress on single mothers and their increased mortality from heart disease and cancer by developing, I used to play Pac-Man. That was my game. Will there be something that goes around the arteries and eats cancer cells and eats arteries and eats everything else out? And I'm sure there will be. It won't be that simple, but it'll be quite the same idea. And will biology win, or will we win in public health or healthcare? Now, healthcare research has taught us a lot. And this, I guess, is an EKG and sort of supposed to show that we have something to do with life. So the first thing I'm going to talk about is health status. And we have known for a long time that health status goes beyond just disability and death. And one of the accomplishments of this field has truly been able to measure health status reliably. if we want to do it. We can measure health status. Now, it's measurable. It's all-encompassing, and I've talked to you a little bit about hate. And just to give you one fact, you know, if you try to measure health status and you don't deal with mental health, you're really not measuring health status. So in the work that we've done and others have done, the reason that people will give up living longer is not because they're impaired physically or even impaired mentally, but it's social isolation and loneliness. How do you develop a society where you mediate or mitigate the effects of social isolation and loneliness on health? Which of you is going to do the PhD work that solves that problem and then implements it? So in the old days of Hopkins, when I was here, we never had an appointment system. Everybody would show up at 8 o'clock in the morning, and they could be seen at 5 o'clock in the afternoon, no appointment system. And one of the great IT advances was to eliminate that waiting and produce an appointment system. And somebody actually did an anthropological study, be a great PhD. Instead of doing secondary data analysis, somebody actually went out, talked to people, and observed what was going on. And what they found is everyone was unhappy because doctors are astrologers. Doctors have people come back once a month because they believe in astrology, not because of medicine. You come back once a month, or you do mammography once a year. Why not once every 13 months or 922 days? We are astrologers. We believe in the calendar. So they all came back once a month. They all knew each other. They brought picnic lunches. It was the social event of the month. Now, am I saying we should go back to no appointment system and all that? No. But am I arguing that we need to think about social isolation, loneliness, and incorporate it into our definition of health? Yes, because people will trade off length of life for less social isolation and loneliness. All of these things are now measurable. Now, ability to measure raises uncomfortable questions, but great opportunities. If you can't measure something, then okay, in this society which emphasizes what is measurable, you don't pay any attention to it. John Galbraith said it best many, many years ago in a book. He talked about the news broadcasts where everybody would talk about the growth in the GDP every month and talk about whether we're in a recession or not, and then ask the question, what is the economic cost of putting a road through a park and destroying the park? If we don't measure it, we have no way of answering the question whether reporting the growth in the GDP is the only thing that's important in our lives. If we don't measure health and don't try to say, could I have prevented this by measuring health earlier, or do I even need to measure health here to decide what to do? What good is it that we spend 50 years of health services research trying to figure out how to measure health? So I would argue that it would be fascinating to come back to Baltimore. Let's make it 10 years, where everybody reported their health on a monthly basis to everybody. Just didn't say health professionals, to everybody. And everybody helped each other maintain their health status. Wouldn't that be a different society? Is it possible? Do we have enough trust in our fellow human beings to actually do that? What if we tried it on something smaller, if that's too big and too really scary? What would happen if we actually had a society that did that? That's the principle, by the way, behind Alcoholics Anonymous to a large degree. That's the principle behind this book that I asked you to read called Social Physics. Read it. It argues that the way you improve your own health is by caring about the health of others. And once you do that, your own health improves. So that's one of the things we've done. And if I were you, what would you, or if it were you, what would you want to happen, and what should we do? Sorry about these slides. Now, the second thing we've done is we figured out how to measure quality of care. Anyone that says we can't measure quality care, that's code for we don't want to. We don't want to spend enough money doing it. It's not important enough to spend enough money doing it. Not that we can't do it. The dimensions of quality have been well laid out. We know how to do it. We know how to measure it reliably. It may cost more money than it's worth. It may be more difficult to do, but we can measure quality of care. Now, I didn't say we can measure quality of care using administrative data produced by claims organizations that have produced it for billing that have no medical logic to it and are run and done in a silly, ridiculous way. That I didn't say, but I said we can measure quality of care. So it's measurable. We agreed on that, maybe. It's hugely deficient in all the three domains that I talked to you about. It varies by location. And no provider does everything well. So I'm stunned by the data that suggests that a general internist, I'm a general internist so I can poke fun of myself, who may manage the hemoglobin 1AC in a diabetic well, doesn't also manage the cholesterol well, or doesn't do a check of the feet well, or doesn't encourage the patient to go to see a dentist well. It's amazing of how uncorrelated within a doctor the different aspects of quality of care are. But this is the data. We're all in it again. We're all in it together. This is the data about quality of care. Now, what do you want to do about it? Is the real question. Now, imagine a world where we had a comprehensive system to measure quality of care. Not just three measures, but a comprehensive system. And imagine that in that world, that you didn't know what the measures were going to be that would assess your quality of care. Begins to sound like a PhD oral exam. You can't study for the test unless you cheat and go to the professor's office the night before and find out what the questions are. Okay? Imagine that it was real time. So why shouldn't every pregnant woman know the quality of care they're getting during the pregnancy while they're pregnant, and they can do something about it? So, believe it or not, the best evidence-based textbook in medicine is an OBGYN, written by a number of Brits. And it lists the kinds of things that evidence suggests absolutely should be due to every woman who gets pregnant. We actually assessed those characteristics years ago in a bunch of practices across the country, and we didn't find a single woman that got all of them right, or a single doctor and woman pair that did them all right. And we found all sorts of biases. So we'd be in an upper middle class practice in Boston, and the OBGYN physicians would never screen their patients for gonorrhea because their response was, gonorrhea doesn't exist in our practice. And we sort of encouraged them gently to maybe try it, and they found a prevalence rate of 5% of gonorrhea in their practice. Asymptomatic. You don't really want to deliver a baby with asymptomatic gonorrhea. Okay? Now, I'm not trying to belabor the individual criteria for quality, but why shouldn't you have a real-time assessment of quality? Why shouldn't I be able to have you go to one of your apps on one of your phones, and right now somebody should be able to tell you what the quality of care you've gotten? And for all of you that didn't get a flu shot, they ought to say your care sucks, or whatever words or language you like best. Okay? Again, if it were you, what would you do? Now remember, there are 3 questions that people want to know. They want to know whether to get what form of therapy works the best, medical, surgical, no therapy. They want to know whether they can get the care locally, or they want to know whether they have to go to the Mecca to get good care. What if they absolutely knew that before they got the care? What if they were part of the process? Okay, what do we know about cost and use? Okay, let's look at that one. People use more care when it's free. Whoopee. The Rand health insurance experiments, that was $1 billion in today's money. It would cost $1 billion to redo it, and I'm not exaggerating. $1 billion to redo a study that the first purpose of it was to say that everyone uses more care when it's free, both the poor and the rich. What was the prevailing opinion in the 70s when that occurred? Was, of course, that'd be true of the poor, but not the rich. Why would somebody who has a lot of money sit in bed with chest pain for 2 hours because it would cost $500 for their deductible to get care? Well, they do. Maybe that's why they're rich. I have no idea. But the bottom line is they do. So we proved that. But we knew that from non-experimental data. This is an example where non-experimental data pretty much showed what the experimental data showed. It just wasn't believed by anybody because it was non-experimental. But the thing that I had to do, since I led the whole rest of the health insurance experiment, was that I had to figure out how to measure health, quality, and why did free care not improve health? Now, I was just out of my military. After I went to Hopkins, I was drafted in Vietnam, spent the time in Washington, so I wasn't in Vietnam. And then, after those 2 years, became the leader of this billion-dollar experiment. That's my life trajectory. It was all luck, total luck. And it was also due to a couple of really important people who were willing to do something different. So I used to have really, really long hair. The only thing left to me that's any good is my hair. I used to have really, really long hair. And I interviewed at Harvard and didn't fit in very well. But they were going to give me a job. Hopkins didn't care at all for what I was doing, even though I was here at that time. And I went to UCLA and Rand, where they were starting this, and they desperately needed somebody, since there was nobody anywhere around that had any concept of how to measure health or anything about quality of care. It wasn't that I was so brilliant. I never would get into this school today, given my grades, if I applied today. So it wasn't brilliance. It was just I was there at the right time. So I walk into this office, and I say, and I always tell people not to interview quite this way. So I talked to the chief of medicine, and I said, you have 1 day to decide whether you want to counter the offer with Harvard. Here's what I want you to do. I want you to make Rand a teaching hospital of UCLA. They said, what? They have no patients. Last time they looked, Rand has no patients. Correct. But I want one job, and I want you to give me one salary, and I want Rand to be a teaching hospital at UCLA. And then I walked over to the president of Rand, whose previous commitment to partnering was with the military, to say, you want me? UCLA is your partner now. And I get one salary, and you figure out how to make it happen. Now, today, if I had done that, the first thing they would have done is call a lawyer. The lawyer would have to solve IT problems, fraud problems, benefit problems, and a whole host of other stuff. But first step would be through a lawyer whose purpose was to delay the process forever, not to solve it. So you never go to a lawyer unless you tell him that I don't want you to delay anything, I want you to solve this process, and you have 24 hours to do it, because they bill by the hour. So I suggested to them that, went home, the next day they agreed. And that changed everything, because it was the first place in the world where clinicians and social scientists could work together while the clinicians still spent time practicing their clinical specialty. Let me repeat. When I was at Hopkins, you either went to the School of Public Health and gave up everything you knew about medicine, and as far as I'm concerned, as a doc, you became irrelevant. You may become an economist or a social scientist, but you became an irrelevant doc in about 1 week. Or you stayed in the medical school and you ignored everything that the School of Public Health has to teach. And literally that was true everywhere in the world. And the example that Rand and UCLA did, only because I was the most obnoxious person under the sun, literally changed everything. And you can see it today at Hopkins and a lot of places. And I've been fortunate to train, over 400 different clinicians that have what I call feet in both camps, the School of Public Health camp, the government camp, and the clinical camp. You don't have to give up being a doctor to work with people in the School of Public Health. And economists don't have to spend all their life analyzing secondary data. They can actually look at clinical data because they can work with clinicians who aren't scared to collect clinical data. So it's a two-way street. Now, pay affects how physicians practice. Duh. I mean, there are a lot of people that believe that we are holier than God. The biologists are the ones holier than God. We are not holier than God, and we change what we do by how much we get paid and for what we get paid. And there have been numerous studies that have done this. My most famous one was when you paid people for the amount of lung tissue that you removed from, how am I doing on time, Albert? For lung tissue that you removed from a person on a biopsy. There were two codes. One, I think, that was 3 to 4 millimeters, and one that was more than 4 millimeters. Nobody removed less than 3 or 4 millimeters. They all took 5 to 6 millimeters, and they got paid more for doing it. So, I mean, this is what we know about cost and use. If it were you, what do you want to know about quality? What is your role in making sure you don't get an unnecessary antibiotic? What if you need treatment for mental illness and the doctor doesn't screen you and you don't get treatment for depression? So how do you deal with all of this cost and use? Now, social determinants. In social determinants, you all know this, so I don't need to preach to the choir where you live. What you may not know is how far you commute may be as important as all these other things. But we now know this is important. Are we going to build two separate systems, one to deal with the social determinants and one to deal with the medical care? Or are we going to integrate this? This is unknown at the moment. In the UK, where a lot of this work is being done, they have put rings around the funding for the NHS and the system that deals with the social determinants of health. It's like a Venn diagram. I keep hoping that they cross as opposed to that they don't cross. What are we going to do? What are you going to do about incorporating the social determinants of health? So in EPIC, the first thing that you ought to have in Baltimore is what is the murder rate in the zip code of the person that just came to see you? What is the average wealth in that area? What does the housing stock look like? I mean, if you really were going to have a combined health medical record, you'd put the two together. And are we going to do it separately, or are we going to keep it apart? How are we going to redesign healthcare? What do we know about medical innovation? Well, some of you have computers here. We know that everything gets cheaper, faster, and better. But that's not true. Innovation is good in medicine, but very, very expensive. And there's been work that's been done to just show how expensive that is. People die in costly ways. And what are we going to do about it at this moment? So if you listen to the head of pharmaceutical companies and everybody else honestly talk about the policy implications of personalized medicine, they don't know which way this is going to go. You're going to determine the outcome. One way it goes is that you have a 3D printer at your home that costs $5 to buy. And you, when you have a disease, stick your arm in the computer, which measures all your proteins and all your diseases and prints you out the drug that you need to fix the problem. Star Wars? Star Trek? Reality? Don't know. There is currently machines that are available that you can do it and measure everything in your blood without drawing blood, but they're bigger than this room. But we've solved those problems before of miniaturization, and we may get rid of blood drawing. What if in 10 years from now we never drew another drop of blood from a human? I mean, you no longer take temperature by doing anything than whisk something across your forehead, right? Do you think I would have believed that 50 years ago? You're not believing anything I say, so it doesn't matter. So, but what would you do here? But the other option is that we have an FDA, that when there are 10 people with diabetes and a new drug, that it costs us $2 billion to bring that drug to market, and it's only going to be sold to 10 people. Even you can do the math before your PhD and decide that's going to make a very costly healthcare system. Don't know which way we're going to go. I hope you all designed the 3D printer. Now, why can't we build on what we've learned? So we really need disruptive change. And I would urge you to spend time thinking about the vision of the world that you want, and take time away from your day-to-day activities. And as a group, come together across institutions and just innovate and be creative and imagine a world 25 years from now. Spend time doing that. Come up with what are plausible worlds. There are methods for doing this. Give you the percent of time that each one of these worlds is likely to exist. Is it worthwhile thinking about those worlds and what you do? I would urge you to make that part of their monthly behavior, using some of these books or something else as a way of making that happen. Now, what if we integrate measurement? We talked about and paid attention to this. This is already talked about, so I'm going to wind up. We actually improved the quality of care. We educated people and providers and gave them smart decision tools to make wider choices. We eliminated the effect of geography on everything. I strongly believe that the requirement for medical school should be geography and not calculus. We radically altered how care is delivered to achieve value and control costs. What if we really wanted to do these things? What if academic medical centers began educating doctors for a value-based culture, or they weren't accredited? Let's just simply change the accreditation policy. Now, we can change every wasteful dollar from healthcare and spending it on animals, ecology, and the earth itself. So I'm going to end here with a story. If you ask me in my life, what is the most thing that I observed that I had no concept was coming down the pike? So in third grade, I remember raising my hand and asking my teacher, what happens when the sun burns out? And the response was, well, that's about 5 billion years from now. You don't really need to worry about it. I became a very happy little boy. I didn't have to worry about the sun burning out. But you're being raised for the first time, and your professional life is beginning for the first time, where the earth is in danger, and animals and plants are in danger. Read The Sixth Extinction if you don't believe it. Not because we're doing anything, quote, bad, but what we're doing so quickly that it's producing so much rapid change that most animal species and plant species can't keep up and will die if you believe what we are doing. And I think the evidence is pretty striking that that's what we are doing. So you have to do all of this change on an unstable planet. So in practice for that, I'm going to make one health change. Tell Albert to get rid of every chair in the department. Replace it with a low-impact treadmill that can't go faster than 1.6 miles an hour, so nobody acts like an ego hero. It can't be raised. It makes no noise. And that all meetings are done standing up on a treadmill. They cost about the same amount of money as a good chair. Sitting more than 45 minutes, which is about the length of time I've talked, is dangerous to your health. Beware. You ought to get up anytime somebody talks at you for more than 45 minutes. It's shown to be dangerous to your health. What if you did that? What if you couldn't come into the building and get your PhD unless you presented your Fitbit and you did 10,000 steps a day? What if we practiced what we preached? What if you did it voluntarily? You said, well, if you do that, we'll reduce your tuition by $10,000 a year. Or we raised the tuition for everyone not doing it. How about that? Is that better? I'm serious. How do we incorporate into our daily practice this concept of what we do? Now, if you want to remember the instability of the earth, why don't you stand on one of those balance balls as you do your work? And then as you balance yourself and have to think about your PhD work and what you're doing in health services, you'll begin to realize just how complex the mental problem is about trying to preserve our planet. At the same time, you're trying to reduce disparities in health and improve the healthcare system. So I thank you for inviting me back. It's a pleasure being here, and I really enjoyed it.
So we have time in this room, bye Al, we have time in this room until 1:30. Maybe we should, since the Freedom Car comes at 1:30, we should maybe go for about 15 minutes, but we certainly have time for questions. So anyone, please. In the back.
How does social class? How do you conception of social class work?
How do I what?
How does the conception of class?
Social class.
How does class fit into
Income
all
class
this?
work into?
Or how does social class get into all of this? Well, all of you know that there are multiple different ways of doing this. One is geography, one is race, ethnicity, one is education, one is income. And for different purposes, most scientists use different measures. But the question, let me flip the question around from a policy perspective. It really does relate to what the world we want. So earlier today, I asked the group, what advantage should you be able to give to your children that somebody else can? So we now know that saying 10,000 words to your child in the first 2 years of life on a daily basis is really critical to brain development. What if you want to give your child 20,000 words? Should be allowed to do that. I'm using the word allowed, and I know economists want to talk about information incentives and behavioral economics. This is all short. Don't deal with the words. Just try to think through what I'm saying. How much equality do we want, and how much difference do we want? For those of you, and that includes me, who are interested in the social determinants of health, how do we value another person's child equally to our own if we're going to survive as a species? So let me spend a minute talking about the pre-agricultural time in Sapiens. And I'm not an expert on this, so some of you may know more than this. So if you read the history of mankind, in order to get more than 150 humans to do anything together, you have to have a myth. That myth could be the Declaration of Independence, a religion, a nation state, but you have to have something to keep people together. It's a myth of how we all keep together, work together. If you have 150 people or less, you pretty much can do it on a one-on-one, face-to-face basis without a myth. So if it's true, let me take you back before the agricultural revolution. And in this book, he describes the following scene. If you became pregnant, every man of the right age in this 150 tribe would have sex with you. Now, why? In order to keep the child alive, every male had to feel like the child was his, so that they all as a community would protect this child. It wasn't a husband-wife dyad and everyone else doesn't give a darn. It was everybody that had to do that. Think about it. Now fast forward, and biology is teaching us that what, 25% of children that think they know their father really don't know their father is when you start doing DNA tests. So we've changed the whole concept of being a human. Think about the diet you ate in the pre-agricultural revolution. What's the nutrition? Variety, grains, berries. Well, that's how they lived. They had big geographic areas, relatively big. They went out and they cut down what was available. And they didn't starve. They ate healthy berries that weren't all wheat and grown and all these crops. So the guy that wrote Sapiens, Yuval, tells you this story and begins to question throughout this whole book, what is progress? and what is progress here. So when I talk about all of this, I think how we begin to think of ourselves as a human species, where all of these differences that we have produced in terms of health and everything disappear, but don't do it in a way that eliminates diversity. Because if you go back and read the book by Rabbi, which rabbi did I give you this book by? Rabbi Sachs, and you read the story as he interprets it of the Tower of Babel. You ought to do that. Anyone interested in the culture of health. Because when you have one overwhelming idea that everyone is going to look like everybody else and everyone's going to be equal, we as humans don't seem to do very well under those circumstances. So your challenge is how to preserve diversity and excitement and ingenuity, and at the same time get rid of all of these inequalities. Not easy.
How do you work inside the box while thinking outside of the box? How does one survive? So I asked for the walking treadmill, and Hopkins wouldn't let me have one unless I registered for a disease. I had to have a disease that said that I needed a walking treadmill.
So my role in life, I've been lucky. So when I was not an Ulster intern, I rejected it. I said, so when I was an Ulster intern, I was spending my nights in the School of Public Health running my cards through the card sorter to produce my dissertation. And I had to fix the damn machine because it would clog and all this kind of stuff. So I won't tell you the problems of the old card sorters and stuff you have. So I said, this is silly, just to stay up until 4 in the morning to prove that you can do it. Culture was wrong. So I went to City. And at City, Hopkins at that time used Baltimore City to do everything that they didn't trust. Anything that could damage the reputation of this place, they threw out at City. So I was the intern on the first live kidney transplant. I was the place where they began, cancer chemotherapy. All of this was out there because nobody knew at that time what would happen with it, including the clinical scholar program. And so we had no fellows. We just had a bunch of young outcasts as faculty who were very bright, a group of interns and residents, and they started a clinical scholar program there. So I grew up, and then I went and met Carr White here. And I almost got thrown out of this department so many times I couldn't even tell you. So I went up to Carr White and said, I don't like any of these classes. You're supposed to be a professor. I want to read books with you. And believe it or not, instead of throwing me out, saying you intern, whatever, he actually said, okay, here's my calendar, find an hour, and I will read anything you want with me. So I spent an hour with the chairman once every week for 20 weeks, 30 weeks, reading the best pieces of literature in the field that either he or I. And so I said, this is great. I've learned more with this than I've done with anything else. So I was lucky. The clinical scholar program was starting at UCLA, and I developed the teaching style where I basically said, somebody else can teach all the methods. What I can do is try to get people to think out of the box. So I spent my whole life doing that. And I annoy people enough that sooner or later I win 1 out of 10, get funding to do something really different and amazing, and we can talk, and that's what I did. But I didn't get another job. And I didn't get another job because any time I went to interview for a dean here or a chairman here, they look at what I am, who I am, and my personality, and they would say, God help us if we take you here. So I tell young people that are beginning their lives that there are 2 ways of running your career. One of them is not to say anything until you get to the position that you think you're going to be at that has the most power in life, and just keep all your thoughts about abortion, women's rights, civil rights, and everything else to yourself. And someday somebody's going to reward you and make you secretary of HHS, and then you can surprise the world with all your thoughts. But you have to realize that you're not going to become president. You have to know when you've really reached that job. Or you can be like I am, and hopefully train a lot of people who go on to those kinds of jobs and make a difference, like David Satcher and others. And you stimulate them to think these thoughts, but they decide to act in a way that's more restrained, so everything they do is not on the record, like this videotape that is now on the record. And I was once told, very early in my life, when I said, why can't I do this or get on this commission? one very wise president of a foundation turned to me and said, Bob, you know how many speeches you give? Yeah. You know, even though we don't have video cameras in these days, there are people in that room that are recording everything that you said, and you're never going to get another job. So the gang of us are basically going to support you to be this kind of a person. We won't support many of them because we'll get fired, but we'll support you to do this. And the chief of medicine I had at UCLA was the most astonishing individual, a guy named David Solomon, who actually realized that this was the future of medicine and did everything possible, as did the presidents of RAND, to say they're going to put up with me. But it was always amazing for that they always reevaluated that decision. At least at RAND they did multiple times. At UCLA they didn't. So you have to decide how to do this. But there's room for this kind of doing it. It would be nice to mix up the group and have people that can serve that role. For those of you that are interested in doing out-of-the-box stuff, I would urge you when you look for a job to try to ask the question of the people and to see what kind of answer you get. How much time is spent on out-of-the-box thinking, as opposed to how can I rewrite my K award so it gets through a study section, which is also important. Good questions.
How do you, oh, go ahead, Tony.
Well, I'm just going to focus on one statement you made about, every time you turn on Epic, it pops up with a neighborhood. And, we actually have something similar to that in Baltimore. It's called the Baltimore Neighborhood Indicators Alliance. It's not in Epic, but you can pull up the website side by side, and you can look at zip codes and see, water quality, ratings of water quality, income, whatever. I happen to live, a couple, maybe a mile down the road, and my neighborhood is people like myself, a little bit better income, people who are not. And when you look at if I were being hospitalized, you wouldn't know anything about me from something like that. And I wonder if you could riff on that a little bit.
So you have a problem if the data, what you're telling me is the data is not as good as you like. My answer to that question is whatever data is good, first of all, include that. If there are data that are not as good as you like, you figure out better ways that you can collect better data to do this. So that would be all I would say to you. The most amazing, you've got to see the work I did at Hopkins as a doc. I'm the only person ever as a doctor at Hopkins that has visited 1,500 patients in their home. I am sure. Maybe there's now somebody in palliative care that's done it. But I went out in East Baltimore and West Baltimore, and so example would be I'd be there at 9 o'clock at night with stethoscope, white coat, and asking them what happened in the emergency room 6 months later. And the response was, we're grateful you're here. No doctors ever come out and do anything like this. But you see what's on the stoop here? Yeah. Well, somebody got shot and killed right where you're standing last night. All of a sudden, what I'm doing to try to cure a urinary tract infection and the realities of life is very different when I can teach people that. I can give slides that actually stand there. I looked at beds where people live, and I said, we tell people with back pain to sleep on this bed that has no support, doesn't qualify what I mean by bed, without even asking them, what is a bed? Now today they all have cameras. They can take pictures of these beds. So they can take pictures of their refrigerator, their room, where they store stuff. This is all doable now. We don't use any of this. When somebody comes in, we don't say, give me your iPhone, let me see what's in your refrigerator, in your pantry, what your house looks like, you have electricity, is it on? I was stunned. I don't know what it's like now in the housing stock here. I just don't know. But I do know that in 50 years, the technology has dramatically changed. And I don't think it'd be an invasion of privacy if you said to patients, if I said to patients who are practicing here, I need you to do all of this for me, to provide a way of me understanding you that will help me decide what I should really do for you as a doc, let alone describing what social services and how to integrate all this, how to deal with some of the broader public health issues. I think that would be neat. Nobody that's tried it yet. Maybe some has, I just don't know of it. But it would really be neat to try to do all this kind of stuff and try to figure this out. I mean, I used to run geriatrics at UCLA, even though I'm not trained as a geriatrician. I would tell all my geriatricians that I was not going to submit a bill that they sent and you're all going to go hungry if you don't have lunch with every one of your patients at least once a year. Out. Not in their home, but out, to see what exactly lunch out means with the patients you're treating. What do they have to go through? How do they have to do it? But I'm a great believer that smell and touch and all this type of stuff. Now, I may be old-fashioned because now the Japanese have developed a cuddly robot. Have you seen this? Now a robot that cuddles. So I can see that we're going to have a breastfeeding cuddly robot and replace mothers in 10 years. And we'll have women go to work 100 hours a week to let men just go around and do nothing. And the cuddly robot will solve all the problems of the world.
Dr. Brooks has inspired so many dozens, if not hundreds, of trainees, public health students, young physicians, and young and not even so young faculty, and continues to do so. I'm re-inspired just by hearing you talk.
Oh, well,
so
thank you for having me, and it really is a pleasure. This is a marvelous set of institutions. I really do hope, and I'm not just saying this, that you all meet regularly with each other, so that at the beginning, when everybody comes here, at least the public health students and the doctors, and you all show up in September, or wherever you all show up now, what if you spend a month together trying to understand culture? And whether those books or some of the way you do it, what if you really did that and really tried to become one team more than you've done so much? And actually, I believe that revolutions start with the young. They're not going to start with the elderly. So it's the students that are going to start revolutions. And this one needs a revolution to really decide what the American vision is going to be like. Because just looking at politics, we have no idea what the new American vision is. It's certainly not the land of opportunity anymore. So what is the new American vision? How are you guys going to produce it? And if you're interested in health, you've got to address that question. So I thank you, really, Albert. It's a pleasure, and I'm glad that you're doing well. And,
Thank you.
And all the people I met that you're involved with, I think you walk on water. So congratulations.
thank you.